Hi everyone, I'm Hannah Aultman, and this is my project. I worked with Dr. Dong. Unfortunately, she couldn't be here today, but she's been very helpful. But this project is looking at whether single-stage revision with an oncologic prosthesis can salvage the multiply revised infected total joint arthroplasty. I don't have any disclosures. Just a quick brief outline, give you an idea of where we're headed. So the good news is that in total joint arthroplasty, the rate of infection is relatively low at 1 to 2%. So that's great news. The bad news is that there's still 1 to 2% of patients who become infected. And once we have chronic infection is established, the rate of eradication of that infection is much more discouraging. It's about 10 to 25% of patients are still infected after a 2-stage revision of a total knee, and 9 to 33% are still infected after a 2-stage revision of a total hip. So this becomes a really big problem once you get an infection. And once a chronic infection has taken hold, there are a couple of options. So the single-stage revision, so this is one procedure. Patient goes in, you take all the hardware out, they get a very thorough debridement, and new hardware goes in. So the benefit is obviously one procedure. In terms of eradication, it's not really as good as, and we'll talk about the gold standard. There's DARE, which is debridement, antibiotics, and implant retention. So this is even less invasive. So surgery, one surgery, the hardware stays in, they just get a thorough debridement and then get IV antibiotics. The gold standard is a 2-stage revision, and this is much more burdensome on the patient, on the healthcare system. So this involves one procedure, all the hardware comes out, large debridement, and then placement of an antibiotic spacer. These are becoming better for patient mobility, but they're still not as good as total joint. And then they have a period of 6 weeks with IV antibiotics, and then another 6 weeks or longer without antibiotics, just to ensure that the infection has been eradicated before a second procedure where hardware goes in. So that's a very long period in a patient's life. And then if those are not options, and we'll talk about why that might be, then we go down the path of resection arthroplasty, which is impossible in a knee but possible in a hip, arthrodesis, or amputation. And those are obviously all very subpar outcomes. So what about that 2-stage revision, and what happens if you fail the gold standard? So that's for that quarter to 33% of patients who don't succeed. So there's a paper in '96 that came out that was very promising, showed that after, they only had 9 patients, but showed that after a 2-stage revision, they actually had eradication of infection in all of their patients. Important to note that all of those patients were quite healthy. Provisi et al. In 2009 looked at their failed 2nd-stage revisions, and they had 18 patients, and 78% did have control of their infection after a second 2-stage. Of the 4 that went on to fail, 2 of those actually had a third 2-stage and did well, and then one of the failures died, and another failure was managed with oral antibiotic suppression. And then just recently, last year with Hansen and JBJS, they looked again at after a second 2-stage arthroplasty. They had 45 patients, and half of them had control of their infection after a second 2-stage. What they did that was different was they stratified their patients based on their host status. So they kind of devised their own algorithm looking at both the host and the extremity. And they did find that those patients who had a worse host grade and extremity grade were the ones that typically failed. So that helps us kind of stratify patients. And then, as you all know, research takes time. So during the course of our study, this paper came out in the Journal of Arthroplasty looking at the clinical outcome using massive endoprostheses in revisions for infection. So this hadn't really been studied. There was one very small case report before this looking at the use of these tumor endoprostheses. So these are used for massive bone loss and for tumors. And so they were just looking at whether or not this was a viable use of this prosthesis to treat infection. And so they had a case series of 69 megaprostheses used for infection, 29 knees and 40 hips. And their recurrence rate was really low. They had 28%, so that's within what we expect for traditional joints. Important to note that the majority of theirs was performed as two-stage procedures, so this is really just looking at whether this implant is effective in managing infection. They did look at the difference between their single-stage and their two-stage revisions and found no difference. But important to note that they had no discussion about whether these patients, if this was a first revision for infection or the fourth, they didn't discuss how many revisions the patients had had in the past. So keeping all that in mind, what we wanted to look at, so we know that two-stage revision is still the standard of care, but it's not always possible. So when we talked about the two-stage revision is a long process in a patient's life. They're usually have decreased mobility because of the antibiotic spacer. It's a long time to be on IV antibiotics. It's just in their two procedures. So maybe patient preference that they don't want to undergo that. Bone loss is a large issue, especially in the knee. There becomes a point where an antibiotic spacer isn't feasible. And so thus doing a two-stage wouldn't be possible for these patients. And then comorbidities. Some of these patients are very sick, and trying to do a long period of immobility as well as two procedures may just not be feasible for them. So we wanted to look at was whether single-stage revision with an oncologic prosthesis, which addresses bone loss, can avoid the amputation in these patients who have been multiply revised for infection, and we already know have very poor outcomes. I would say our hypothesis is yes. So our project design was a retrospective chart review at a single tertiary referral academic center here. And we looked at all patients who had undergone multiple revisions for infection and then a single-stage revision for infection with an oncologic prosthesis performed by one of two fellowship-trained tumor surgeons, Dr. Dong or Dr. Hayden, from 2010 to now. The prosthesis we used was a modular limb salvage system that allows for a single unit for bone loss 3 to 5 centimeters, and then anything over 7 centimeters requires a modular prosthesis. Our primary endpoint was failure, which we defined as a need for amputation or resection arthroplasty. And our secondary endpoint was reinfection, so a need for revision for recurrence or new infection. We collected a lot of data. Pre-op data, we mostly looked at their labs and any aspiration and cultures. Intra-op data, so we looked at the frozen section that was taken intra-op, the final pathology with cultures, both tissue and synovial, and then amount of bone loss we quantified. We looked at the patient characteristics because we knew that from the Hansen study that's important. We looked at their ASA grade and their Charlson Comorbidity Index. And then post-op data, we looked at whether they completed their IV antibiotic course, whether they needed oral suppression, if and when they needed revision, and that indication for revision. And then also looked at their ambulatory status as a marker for their outcome, since we don't have patient outcome scores, and then their most recent follow-up. So we looked at, I think, 200 patients. 22 patients fell into this category. There were 10 men and 12 women. They had an average age of 69.2 years. Their average ASA grade was 2.77 with between 2 and 3. And their mean Charlson Comorbidity Index was 4.5 with a range of 0 to 9. So they actually weren't that sick, and I think that's important. We kind of looked at whether we could use the algorithm from the Hansen study, but these were actually not very sick patients, which is good for them, but didn't help us stratify them. So the mean number of surgeries prior to single-stage revision in these patients was 3.8 with a range of 2 to 10. So important to note that these were patients who had failed multiple times. They just really didn't have other options. And also important to note that our mean bone loss was 16 centimeters, so a range of 3 to 27 centimeters. And only 4 of our patients, so less than 20%, had bone loss of less than 10 centimeters. So these were really not patients who could tolerate a two-stage revision because there was no option for an antibiotic spacer. So our outcomes. So our overall implant retention rate was 72%. So that was in line with other studies using traditional total joints. 10 of those 22 patients, actually, so almost 50%, had no further surgical intervention. They were able to go on their merry way. 6 of 22, so about a quarter, did have a revision, but were able to retain their implants. And then we had 6 failures, so that's 27%. with 5 amputations and 1 girdle stone. Our average follow-up was 77 weeks with a range of 6 to 180. One patient died at the 6 week, had died at 6 weeks. This is just to, ooh, that didn't project as well, I apologize. But just to give you kind of a visual feel for what happened to these patients. So in the total hip, we only had 7. 2 of those were able to go on with retained implants and no further interventions. 1 patient did have a revision and then went on to girdle stone, and 4 patients had more than 1 revision but were able to retain their implants except for 1 who went on to amputation. On the total knee side, there were 15 patients. 7 of them, so almost half, were able to retain their implants without further intervention. 7 patients had 1 revision, but 4 of those went on to amputation. And then 1 patient had more than 1 revision but retained implants after that. So looking at our failures, again, small numbers, but 6 of 21, so 29, apologize, that should be 27%. So our 2 total hip failures were both due to VRE infection that was resistant to oral antibiotics, so they did not have an oral suppression choice. And so 1 was a girdle stone, 1 was a hip disarticulation, but neither of them had a choice in terms of long-term management other than resection. And then of the total knee failures, 1 patient had periprosthetic fractures of the distal femur and the proximal tibia in the set of recurrent infection, and she had actually opted for a above-knee amputation. She didn't want to have further surgery. 1 patient had resistant Pseudomonas, again, not treatable with oral antibiotics long-term. 1 patient developed full-thickness skin necrosis overlying the prosthesis and didn't really have an option in terms of skin coverage. And so that's when underwent amputation. And then 1 patient had profound and poorly controlled lymphedema that we had worked for a long time to try to control, but she continued to get infected. So after a long discussion with her, she opted for an above-knee amputation. Just for the visual people in the room, there's a Kaplan-Meier survival. And then in terms of outcomes, again, I mentioned that we don't have patient outcome scores. It's not something that we collect in clinic. There has been discussion about this. But so our proxy was ambulatory status and complications. So we had 4 out of the 22 who were ambulating unassisted, which is impressive for most oncologic prostheses as is. And a patient who's been multiply revised, I'm pretty happy with that. 3 out of the 22 had a cane, and 1 out of the 22 actually preferred crutches. So that's quite a decent number who are still ambulating, not requiring a walker or a wheelchair. And then a quarter of them are still using a walker, and a little over a third are using a wheelchair, and that includes the amputations and the girdle stone. Oh, sorry, complications. So as we discussed, so 50% of them had recurrent infection. We did have 3 of the 7 hips have a dislocation. Again, not uncommon in an oncologic prosthesis. Wound breakdown, I actually only had 1, which is, in the tumor world, that's great, we'll take it. Broken hardware, we had 1 patient, that periprosthetic fracture that I discussed, and then 1 intra-op cardiac arrest. But again, these were not as sick as I was anticipating before going through. So in terms of further analysis, obviously these are small numbers. A case control, we were hoping to have, there were only 13 patients who've had 2-stage revisions to oncologic prostheses, but that may be something we could consider. And then longer follow-up, we would love, it's hard, these patients come from all over the state, they often come from out of state. They usually often follow up out of state, so we lose a lot of them. We don't know. I think we could do a better job tracking them and getting their outcomes. More patients would be great. Luckily, it's kind of nice that we don't have a lot of patients, because that means that these patients, there aren't as many requiring multiple revisions. But at the same time, obviously, for numbers, it would be great to have more patients. And then patient-reported outcome measures. I think that's something we could discuss having happen in the tumor clinic. That's what I've got. And a special thank you to Dr. Don, who again isn't here. Dr. Priest.
So, as you sort of mentioned, you have this group that seemed a little healthier than you expected, and the data seems to suggest that that group maybe has a higher chance of success. I guess my question is, should you be getting to these patients earlier? I mean, is there a role for, if you failed one two-stage revision, should we be doing a second two-stage revision, or is this the answer behind that? Because the second
Right.
two-stage revision, there's a lot of morbidity that comes with that, and maybe we're putting you in the bad category where we can't salvage it.
Yeah, I think that's a great question, and I think, you know, these are with tumor surgeons, and I bet if you had this, had this discussion with joint surgeons, they would advocate a second two-stage. So I think that's just kind of a philosophical difference, and probably, you know, the way the two trainings approach it. I think that would be a great discussion to have between the teams. I mean, we have our joints conference that's between tumor and our total joint surgeons. So I think that there is some cross-pollination there, but I'm not sure that happens at many other places, and maybe that would be something to look into, yeah. Yeah, Dr. Ladd.
Thank you, Hannah.
Sorry, I didn't repeat my. No, I'll repeat it. Sorry, I didn't repeat Dr.
Yeah, thank you.
Reese's.
Thank you to the chiefs. I was really enjoying reviewing your papers. I did have a couple of questions. So I don't have a clear understanding of what is the normal rates for revision and et cetera. Ooh, quite loud. For two-stage reconstruction, because that's what you're comparing to. So
Right. So for, let's see if I can. So for after a two-stage revision for infection, about a quarter of them still fail
okay.
and go on to need, yeah.
So you're implying
And that's for their first infection. You know, and so we're looking at, this is down the
2 and
road.
3.
Yeah,
So
which those numbers aren't out there as consistently. Those are really case studies.
So you're implying that you're comparable and it's more cost effective.
That's, yeah. Well, versus an amputation. We're really looking at, can we salvage these patients?
Sure.
So I think important to note that all our patients do, one of the studies counted a failure as needing lifelong antibiotic suppression orally, and all our patients required that. So I think that's kind of, we're looking at very different, because they're so far down the line.
Sure.
Our outcomes are just hoping that they can have a functional limb.
Sure.
Versus, and kind of accepting that maybe infection eradication is impossible for these patients, whereas after a two-stage revision, they're still hoping for infection eradication. So it's, yes, you're right, apples and pears.
So given that it's a rarefied air, a really bad problem.
Yes.
And it will be really hard to do those case control and
Yeah.
et cetera, are you considering and just reporting it as case reports?
Yes, so that's where this is now.
Okay.
I think down the line, it would be nice to look at whether, we had talked about a case control. I think the inherent problem, again, is the reason these patients don't undergo two-stage is because they have too much bone loss, or there's another reason they can't,
Okay.
because our goal would be a two-stage if possible. Another thing we could look at, which our team does, is a very shortened two-stage, and they take out the hardware, put in something that really isn't stable, but give them about a week in the hospital with just some cement, just for the idea of having hardware out for a little while and see if that's effective. That might be the appropriate case control, because it's still the same host. It's still the idea of the bone loss and the comorbidities.
And one more thing, you might consider doing
Sure.
a cost analysis
Yeah.
relative to this population versus a two-stage.
Yeah, I think that would be great. I think if I don't, with the numbers, they're so small. It's such a small impact, but I think, yeah, for just,
The kind of projection.
amputee and, yeah, absolutely. Thank you. I'll go with Dr. Tower first.
Yeah, and the single-stage revision for infection is becoming more and more popular. A lot more people are talking about that. I know
Yeah.
Dr. Faring, I think at Ortho Carolina, talks, spends a lot of time talking about the technique of doing the single-stage revision. He calls it this particular case series with your single stage revisions, are you following that type of protocol in terms of draping and?
No, no, these are kind of your standard draping. We are coating the prosthesis with antibiotic cement. I think that's the one difference, but I mean, you're not double draping at all, Dr. Gundel.
I think it's great to look at big challenges, in terms of finding things for research. Do you think, since the microbiology of this is such a driving force and the driving force of some of your failures, do you think we should be studying this specifically for certain organisms, like matching treatment to an organism,
Right.
rather than considering all of these infections the same?
Yeah, I think part of the problem, so Dr. Gundel was asking about whether we should look at organisms and maybe the specific organism should drive our treatment rather than necessarily like the number of times someone's been revised. I think what was important for these patients, like the two who got VRE and had to undergo amputation, that showed up later. So they didn't start with VRE. So I think that's part of it is we call it reinfection or recurrence of infection, but a lot of these patients have actually evolved in their microbes. And so you're right, somewhere along the line, if you see VRE, maybe that's the time to have a different discussion with the patient. But for these patients, unfortunately, they've already undergone multiple procedures, and this is probably something to do with being in and out of a hospital quite a bit. But so, yes, I think that would be great if they started with VRE. Unfortunately, they often develop it late in the game. Yeah, Dr. O'Fallon.
Quick thought. So it seems like a hypothesis underlying this is that in this population, the paradigm that osteomyelitis is a medically treated disease is probably incorrect, either because of the virulence of the bug or because of the devascularization of the bone, or both, right?
Mm-hmm.
And doing a more aggressive debridement allows you better clearance rates. But you're even in the knee, you're probably only doing an aggressive clearance of one side, right? You're not using segmental bone replacement of both femur and tibia. And in the hip, you're not ever doing it for the acetabulum, just like in the shoulder, I'm never really doing it on the glenoid. Do you think that's potentially a problem? Do you think we need to kind of really look at expanding, the extent of our radical debridement, almost as if this was a tumor case, and, doing whatever it takes to remove a wide margin of infected bone?
Sure. So Dr. O'Fallon is asking about kind of if these patients, were thinking about them both as having infected implants but also infected bone and osteomyelitis, are we not debriding them adequately? And maybe we need to look at, especially in the hip, where one half of the hip is difficult to debride and also then difficult to replace in terms of hardware, is maybe do we need to start doing more debridement and accepting more endoprostheses as a result? And yeah, I think we don't have a good answer for the hip. I think that's part of the problem is that, we don't have a good acetabular answer, same as the shoulder. We don't have a good glenoid, scapular replacement. But yeah, I think and I think a lot of people in the joints literature think that inadequate debridement plays a large part in like recurrence of infection is really you never got rid of the infection in the first place. But I think our technology may not be there yet.